Hello and welcome, friends. I'm Dr. Chana Davis. I'm a geneticist and contributing writer at Nerdy Girls, and I'll be your host today. I'm joined by Dr. Jenn Dowd, our awesome editor-in-chief. Jenn is an epidemiologist and demographer who studies mortality trends and how social factors get under the skin to impact health, including infections and immune function. She's a professor of demography and population health at the University of Oxford and deputy director of Oxford's Leverhulme Center for Demographic Science. Jenn grew up in Nebraska and Texas and currently lives in London with her husband and three very grown-up children. So
That's
hello,
right.
Jenn. It's good to connect with you.
Yeah, great to see you, Chana. Yes, my kids actually just graduated from high school, my twins, last week. So it's pretty
Wow,
huge life transitions here at my house.
absolutely. So before we dive into today's questions, I just want to mention that these are all questions that came into our question box on the website. So we're not taking questions cold. And if you want your question to be considered, please submit on the Nerdy Girls website at thosenerdygirls.org. So let's jump right in because we have a lot to cover. Jenn, can you start with how high is the COVID risk right now? This question came in from Kat in Montreal.
Yeah, great question, Kat. It seems like something that we've been tracking meticulously for 3 years now. And I'd say the bottom line is that COVID is likely a lot lower than it's been for, the entire pandemic is what we're seeing, which is really good news. It's definitely still with us, but the really great part is that we're seeing many fewer hospitalizations and deaths.
Mhm.
So we're kind of in this different stage of the pandemic where the CDC and the WHO have shifted their response from something that they called an emergency response to thinking of COVID as a bit more of an ongoing public health issue. And so that had, some knock-on effects as far as collecting data. So one real downside of shifting from the emergency mode was that we've lost access to some of our great sources of data that we had in the past to track the virus. And so, besides some changes in how cases just get reported from local health departments or hospitals, we know that people just are not testing the way they used to. And if they are, it's often these home rapid tests that were never really reported at the national level. So we are flying a little bit more blind about the level of cases, but we can really still see hospitalizations and deaths, which are trending in a really good direction and lower than they've been in a really, really long time.
Mhm.
But that loss of data, I think, has been sad for us data nerds
Mhm.
who really, had found some power in being able to watch those trends over time. And I know a lot of our readers actually, like to know what's going on in their local areas, especially if you're immunosuppressed or someone in your family is. You kind of want to know the COVID weather forecast as it
Mhm.
might be, so that you can plan a little bit better what your risk is. So there is one challenge with less data, but we have a couple things we can still look to. There's been something new on the scene during the pandemic called wastewater surveillance, which is kind of exactly how it sounds. Local areas, testing their sewage for basically COVID, genetic material. And this is, grown in popularity. So I think there's over 1,200 local sites in the US right now that report this type of data and give us a decent picture, at least, of the trends, and even the levels compared to earlier in the pandemic. So wastewater surveillance is something I think we're dropping a link to that we keep an eye on. And it's also showing that we've got quite low levels. And then there's still some testing that we can rely on, such as in hospitals and emergency rooms. And again, we're seeing quite low levels right now, which is great. And I think that's also true in Canada. Is that right, Shauna?
Yeah, absolutely. It's a similar situation. We're piecing together multiple different metrics like wastewater, hospitalizations. Um, I don't know if they still formally use this, but they've been tracking, for example, what proportion of ER visits are COVID related. And all those metrics point in the same direction. So they're each imperfect, but they're all trending in a good direction and have been for a little while now.
Exactly. So, at least that weather report it's a bit sunnier than it's been in a while, but we
Mhm.
have to be on the lookout for the clouds on the horizon.
Yeah, so I'm going to drop links in here for those that like data. We have the CDC tracker and the Health Canada sort of state of COVID website.
Okay, so next question is for you, Chana.
Hmm.
Also, Kat from Montreal. So
She had a
Kat is
very multi-part question. Yeah.
she's a big nerdy girl. I love it. Okay, are the new variants more or less infectious?
Mhm. Well, the short answer is they are more infectious. Well, they're more transmissible at least, and that's sort of a result of being able to spread better, but also being able to evade the host's immunity. And at this point in the pandemic, most of us, the vast majority of people, have some level of immunity. So really, you kind of have to think about this variant landscape as kind of an arms race for different variants to try and trump each other, and so you expect to see a trend towards variants that are better able to spread because they can spread better than the previous one. And that's in general what we've seen. We've seen successive waves of variants being better able to transmit throughout the population through a combination of being more contagious and being better able to evade the current level of immunity in the population through different mechanisms. Being able to evade current therapeutics is also an aspect of that. So yeah, the right now the dominant variant, XBB 1.5, people call Kraken sometimes. That one we have some good support that it's both more transmissible and better at immune evasion. And the Arcturus variant, it's still pretty early. That's XBB 1.16. That one, people are saying it seems to be very similar to Kraken, maybe some enhanced transmissibility on top of that. But um, as you probably know, this can be a little bit frustrating to really put hard numbers on because it does really take months to study these in a really rigorous way, and often we have a new variant by the time those studies are done. So when you look at some of these pages that summarize in a snapshot of what's the attributes of different variants, they often say no evidence of. So they might say, well, there's no evidence it's more severe. It doesn't mean it's not, but there's no clear evidence it is. So it's sort of an
Right.
innocent until
And
proven guilty. When you look at some of these tables, they say, well, it's not dramatically different than what we've seen. So it's probably not, but it still could be in a subtle way.
yeah, and as you were saying, we have such a different immunity landscape now
Hmm.
with, almost every combination you can think of, vaccine combinations and previous infections. So I
Hmm.
think that makes it really hard then to see, the inherent characteristics of the new variants. Would they
Hmm.
be more, cause more severe disease or be more infectious compared to the original variant if we were all immune naive, or
Yes.
what's the deal? But I think the good news is on the severity front, it seems like, the lower levels of hospitalization and deaths are really, telling us that our
Hmm.
population immunity is at least starting to protect us in
Hmm.
that way. So that's
Yeah.
exciting.
Yeah, so I can drop some nerdy links in for this as well. I've got a link from the CDC on how they track variants, which gives you this nice bar graph of the current composition. And then there's a nice table I found from the European Center for Disease Control that has these nice summary tables of what's the current variants of concern, variants of interest, variants that are being monitored, and just a simple table showing, are they more transmissible, are they more severe? And often you see basically these hedging statements that no evidence yet, but we can't rule it out. But in some cases, they actually do have concrete evidence something is more transmissible. But yeah, overall,
Very
we're
cool.
seeing we're seeing trends towards more transmission, but not a lot of differences in severity. So
Fingers
let's
crossed.
let's shift gears and talk about precautions, and with boosters as the front and center topic of conversation that we want to update everyone on. So, is there going to be an updated COVID booster in the fall?
Yes, I can say the good news is, it looks like updated boosters are going to be on their way to us, probably in the fall. And the US FDA Advisory Committee panel, which I call VRBAC, I don't know if that's the right pronunciation of the acronym, but they met last week on June 15th and discussed the future of COVID vaccines in the US. and they made a recommendation to update the formula to an XBB variant. And the WHO did the same back in May, also recommending an XBB, as well as the European Medicines Agency. So there seems to be good consensus, and the fact that we should target this XBB variant, which does comprise, I think, between 95 and 99% of circulating COVID right now. So that's good, because last summer when we were deciding this, there was a little disagreement about including BA1. Some countries in Europe did that, and the US did the split of BA4 and 5. So it seems to be really obvious, I guess, which is a good thing right now, that XBB is the way to go. And there were a few key, I think, takeaways from that meeting last week, that the fall boosters will be comprised of just one of the XBB variants. And it turns out, we have mostly XBB 1.5, I think, is still dominant. The XBB 1.6 that you mentioned is growing a little bit. But there were several presentations that showed that these are so closely related. They're, very close relatives of each other, that a vaccine, targeted at one of those spike proteins will protect very well against all of them. And so I imagine there's some practicality in the vaccine makers, focusing on one variant, but also there were some mice models that showed, just making a formula focused on one, might even elicit a better immune response than one that kind of divides it up into several of the subvariants. So, so we're going to have one back to a monovalent XBB, and it sounds like it'll be 1.5. And interestingly, the original SARS-CoV-2 strain will be dropped. So this ancestral strain that we've had in the vaccines since the trials, since the earliest days of 2020, is finally going to be dropped. And I think, this is a really good move. It makes a lot of sense. So last year, even though we had this bivalent booster this past year, but that was actually still half of the original formula, the original strain, and then half of a mix of BA4 and BA5 variants. So it wasn't really truly fully updated. It still had this portion of the ancestral strain. And I think, we know that ancestral strain is extinct. It's not circulating anywhere anymore. We've had all of these offspring that we talk about now, and it's very unlikely that we'd ever see that crop up again in its original form. And so I think one reason for dropping that entirely is this idea of immune imprinting, which it's not quite as scary as it sounds, but it means that the immune system kind of favors recalling something it's seen before. So, we were finding with the bivalent vaccine last year, where it was a mix of the original and updated variants, that there was a bit of a stronger immune response to the original ancestral strain than the updated strains, because we'd already seen that before with the prime series of the vaccine. And so now that that's completely extinct, we'll be better off focusing all of our immune resources on these updated variants. And so that's kind of a more forward-looking opportunity for our immune system, because also new variants that emerge will probably be closely, related to XBB and its descendants. There could be one that comes out of left field. But I think, going to this 100% updated formula is going to be a really good thing. And Novavax, Moderna, and Pfizer are all planning to, poised and ready to make this updated XBB booster. So you'll have all of those options ahead of you in the fall. And finally, the timing and eligibility.
Oh, hold on a second. I want to drop the link to that first, and then just I was gonna just shout out, because I forgot to mention two of the questions specifically. So Deborah from Aurora, Ohio, was one of the people that asked about that, as well as Marianne from Plymouth was asking about the Moderna booster, whether it will be updated. So thanks for your questions.
Thanks for those.
And I don't know if you're about to mention this, but just to be clear, the XBB is part of the Omicron family. And so When you got an updated bivalent booster, you were getting something that is closer to what we have now.
Yeah, no, that's a good point. I should have said these are all Omicron
Mm-hmm.
descendants. And so it's really interesting because it's been a long time then since we've seen a really huge leap in the family tree
Mm-hmm.
of variants.
And if you want to
And,
see the family tree, you can go to the link that I sent the 2 links ago, I guess. There's a nice, there's multiple places. You can just look at like phylogeny of
yeah,
SARS-CoV-2 variants, but the second last link does have a nice phylogeny. Maybe we should just post that
yeah,
sometimes. Like
they're
how
really,
are all the
really
variants
cool.
related? Because it's cool to see the family tree.
Yeah,
Yeah.
no, I love those pictures.
Hmm.
Um,
So booster
and
timing, can I just mention two specific questions and then you can talk about it more broadly?
yeah,
Um,
yeah,
so so sorry, I'm just gonna get this general question about it. The general question is, when should I get a booster? When should my family or loved one get a booster? And two of the specific questions we got were one from Margaret in Franklin, New Hampshire. Should older folks who have already had 5 doses of COVID get another booster? And then another one asked, my friend who's 80 received her first booster in April. How long should she wait for her next booster? And should it be the new bivalent booster? So there's been lots of questions like this. Those are just two examples.
yeah, we've gotten lots in the comments of our post too about
Mm-hmm.
specific timing. And I just wanted to also say that we haven't heard exactly when the updated boosters will be
Mm.
available or what the official eligibility will be. That's going to happen with the CDC and the ACIP meetings a little bit later this summer. But I think there's an expectation that it would be available in September, similar to last year. And I would assume there'll be wide eligibility. There might be a difference between, who's recommended to get it, might be older and more vulnerable, but that, pretty much everyone, I think, is likely to be eligible to get it if they want.
In
So,
terms of
and
adults, anyways, right?
as far as adults, I've heard,
Yeah.
yeah, I guess, yeah, there's different formulas and things, but we'll have to see how it goes for the kids.
Mm-hmm.
But so I know a lot of people then are worried about this timing because there was just an opportunity, that started this spring to get a second bivalent booster
Mm-hmm.
for people in vulnerable categories. And some people may have done that really quickly in the spring, but some may have had a recent infection and waited. And some people might have just missed, those cycles last year of the bivalent booster and be interested in getting it now. So, you know, just to say from the start, it's hard to give universal recommendations because, as we've said, everyone has their own particular mix of vaccines and previous infections and risk factors. There's an infinite number of scenarios, but
Mm-hmm.
I guess as I was trying to distill what how I would think about this myself, I would say in general, it's probably best to wait, 4 to 6 months at least since your last booster or infection. Just because you're not going to get as much, you're already protected pretty well after a booster or an infection for several months, and getting another boost on top of that, it's not going to harm you, but it's kind of wasting that opportunity to, there's kind of a ceiling effect. You probably can't top up your protection that much if it's very close to a previous infection or booster.
Can
So
I can
I'd
I
err
just can
towards
I in
6 months.
okay, yeah, and
Yeah,
can I
please.
interject in support of that? That in Canada has taken a stance in general of stretching out the interval, and there is some evidence that a longer interval can actually give you a better boost.
Yeah, there's kind of this something called affinity maturation, I think, where your antibodies even get a little more sophisticated as time goes by at identifying other variants. So, it's fine, I think, to, I would err towards 6 months at least if I'd had an infection or previous booster. And so I think, the tricky part is if you're getting close to that window and you're feeling vulnerable for whatever reason, you're in a vulnerable category or you have a big wedding that you don't want to get sick for, etc. And because, again, this is not inside knowledge I have, but because I think there's a good chance these will be available in September or early fall, and we're getting kind of close to that, I would probably side with waiting for the new formula. And, for me, the reasoning really is about the updating to XBB, which is exactly what's circulating right now. So I think we would expect that formula to really be much more effective at blocking even infection right now. And like I said, that old, the current bivalent booster has half of the very original ancestral strain still in it, which kind of tilts your immune system a bit backward looking towards, those previous variants instead of to the future. So
Mhm.
I would kind of be inclined to wait it out. Also, as we said, COVID levels seem to be, at a low level right now. If we suddenly heard of a big surge,
Mhm.
that might be a reason to go sooner.
Yep.
Um, but that said, everyone's situation is a bit different. If you do get one now, you'd probably be eligible then to get the updated one in, 6 months or so. So they're all reasonable decisions, but
Mhm.
I think we're getting close enough that for a lot of people waiting for uh, the new updated, shiny version might be a good idea.
Mhm.
And mostly, we really want everyone to go get this when it is available because, the uptake of the bivalent vaccine last year in the US was kind of abysmally low. We had
Mhm.
only 17% of the US population get the bivalent booster at all, and only 43% of over 65s who are really at much higher risk of severe COVID. So I hope we can kind of rally and maybe market this updated variant formula for what it is, and get people a little more excited about protecting themselves this fall.
Mhm. Um, yeah, just to comment on the value of boosters overall, even these imperfect matches against the variant landscape are providing good protection against severe disease. But the reduced protection is mostly in terms of do you get infected or not, right? Um,
Yeah, absolutely. And I think, that's a question mark. We don't really know how long the protection against severe disease from if you
mhm.
just had the primary series, how long would that last?
Mhm.
But I think, again, kind of giving your immune system a new education with the updated variant makes a lot of sense. And you probably will have pretty high protection even against infection for 3 to 4 months, which,
Mhm.
is not nothing. It's not perfect. We wish it were longer lasting, and we can't really time the seasons of COVID yet, unfortunately. But for me, knowing that I have 3 or 4 months of really high protection against infection, makes it worth it. Definitely lowering your chances of long COVID, all sorts of benefits, and just not infecting
Mhm.
others. So
Yeah, peace of
so
mind.
I'm
Mhm.
excited. I'm excited about the updated variant
Awesome.
booster. All right. So we move
Sure.
on to another one for
Let's
you,
move on.
Chana. Um, you're kind of the guru of all things about COVID
Mm.
transmission. Do we have any clarity about the length of contagion? So how long someone is contagious, or when are they most or least contagious with
Mhm.
our current strains of COVID-19? And this is from Laura from Connecticut.
Yeah, I went on a bit of a research mission inspired by this question to see if we have new studies on the latest variants. And unfortunately, we don't have, I couldn't see anything published yet, which it maybe is not surprising given how long it takes to do a study and let alone actually publish it. And so most of the information comes from basically speculation from public health experts who are, saying, based on what we know, this is our best, most educated guess rather than concrete studies with numbers in them. And what
Yeah.
they're saying is they don't really see any reason to think it will be different than previous Omicron variants, BA1, BA2, BA5. Um, FYI, the current Omicron variants are descendants of BA2. So I was looking at BA2 data in particular to see, what those show, because BA1 and BA2 are a little bit different. But in terms of, so let me just lay out some of the, basic stats of timelines and what you can expect. So the first thing is the incubation period, which is on average about 3 days. It can be between 1 and 10, but usually it's between 2 and 4 days from the time you're infected till the time you have symptoms. And that is a little bit shorter than the ancestral strains, but it's not different than that. This is the generic Omicron family description, which we think applies to the current XBB variant. So an incubation
Right.
period of around 3 days, and which also translates often to a serial interval of roughly 3 days. So if I'm sick on Sunday, then 3 days later, someone else in my family is when they're going to test positive. So that's the serial interval is the interval between two people testing positive who are, exposed. One who gets it, someone gets it from the other. So you sort of
Yeah.
expect this 3 day lag between rounds of cases, and you expect in yourself 3 days from exposure to symptoms. Now, the contagious period is a little different. Um, it is 1 to 2 days before symptom onset, and on average, about 5 days post symptom onset. So you're looking at about a week total. Um, but it also that varies from person to person. And so then back to the question, the original question is, oh no, sorry, I was jumping ahead to the next question about rapid tests. But so that's the best guidance. But I think the guidance to be conservative beyond that, and the original guidance from CDC was, isolate 5 days. Or the most recent Omicron guidance was isolate 5 days and then mask 5 days. I think that still makes sense based
Yeah.
on what we see as a generic timeline.
I think, yeah, that sounds about right. And I know a lot of people like ask me now because people are still getting infected and don't really know what that guidance is anymore.
Hmm.
And I think it is important that the 5 days is not a magic number,
Yeah.
that if you have the ability, to be a little more cautious and stretch it out, or mask if you have to be out even after
Hmm.
5 days, then yeah, to me that's a better way to go. But that
Hmm.
does tie in very well with like, how do we know if we're still contagious? Can we
Hmm.
can we hack that and figure it out? So are rapid tests still good indicators of current contagion, or is there a better metric?
Yeah.
Also from Laura from Connecticut.
Um, I think the best metric for contagion is a combination of where are you in your infection course and what does your rapid test say. I think you use those two pieces of information together. That's the best way to go. So early on in infection, a day or two after you're exposed, even for a couple days after, rapid tests are very prone to false negatives. So even if it's incubating in you and you're highly contagious, you could still get a negative result. So they can be misleading early on in an infection in terms of a false negative. But once you get later into infection, am I done at 5 days, or am I still a risk to others at 7 days, 10 days? I think then they can actually be a little bit oversensitive. But for those that want to be conservative, it's a really good way to go. What I reached out to a few experts in the field about this question that has come up a lot. It's day 10 and I'm still positive. Does that mean I'm contagious? And we don't honestly still have a really good answer to that. The answer I would get that I typically hear from experts is it makes sense to be conservative at that point. You might not be, but you're more likely to be contagious than someone who's negative on day 10, right?
Yeah, 100%. And why take a chance if,
Hmm.
and it totally depends, I realize, on your life, but
Yeah.
masking in that situation if you really must be out is, a good idea as well.
Yeah.
Yeah.
And like, how do we know that people are looking at this in a couple of ways? They do these studies where they compare the results of a rapid antigen test to what's considered the gold standard, which is to try to see if you take a swab and if you can grow virus from it in the lab. And we see a pretty good concordance between those two, but it's not perfect. So in general, if you have a positive rapid test, they can probably grow virus from your swab in the lab, but not 100% of the time. If they can't get anything off your nose, they probably can't grow anything in the lab. So it's still an imperfect indicator, but it's still useful, especially later in infection, to see how your relative risk compared to others, I think.
Yeah, and
And
that's definitely how I'm still advising family and friends who are texting me, "Oh,
mhm,
it's past day 5, but I'm still positive. Can I
mhm,
go, yeah, pick up my grandchild and
right.
take them somewhere?" And I'm like,
Yeah.
I would wait. I would postpone that a few more days
Yeah.
if you can.
One of the little tidbits that made me feel um, like it's worth taking those seriously is some of the studies I looked at of Paxlovid rebound, where those rapid tests became positive again, and there's anecdotes of people spreading it during
Right, right.
rebound, corresponding with getting a second round of positive rapid tests. So I think there's enough reason out there to be cautious in that situation.
Yeah, absolutely. It's better than burying your head in the sand and just
Yeah.
pretending you're not contagious.
Yeah. Um, so just two final tidbits that I just want to drive home in rapid test. So it's worth testing early as soon as a day after exposure, but you can't take a single test as a definitive result. Ideally, if you have access to multiple tests, test every 24 hours for about 5 days. And if you only have one test, interestingly, your best chance of getting a true positive result is around day 5 after exposure. So even though your symptoms might be receding, your viral levels will be highest typically around day 5 after exposure. So if you just have one test, lay low and take precautions, but then if you're just gonna double down on the timeline, that's when I would suggest doing it. Not just me. That's what the experts suggest doing it is 5 days after exposure or about 2 days after symptom onset, which will not correspond with your peak symptoms.
Super interesting.
Yeah. So let's just wrap up with a question about Paxlovid. So what does it mean that Paxlovid obtained full approval in adults?
In adults, yeah, this just happened, I think in May, that Paxlovid moved from the emergency use authorization in the US to full FDA approval. I will say it's still under EUA for kids ages 12 to 17. So it crossed the threshold for adults. And, I think there's, without going into the details, this means that it passed a higher standard of evidence for safety, which probably had to do with a longer follow up period, et cetera. But the practical side, it also means that there's more flexibility for doctors, because once a drug has full approval, a doctor has the ability to use it a bit in what's called off-label use at their discretion. So again, just my understanding from some of our clinical nerdy girls is that this authorization now means that if a doctor did feel like a longer course of Paxlovid was warranted for an immunosuppressed patient, for example, a high-risk patient, they might be able to do that. I think there were a lot of people asking if, especially if they were high risk and about to take a trip abroad, is that something they could get before they leave?
Mm,
And doctors were not allowed to do that when it was under EUA. But I think again, it depends on the personal, the particular physician. But there would be scope for a prescription to be given for someone who high risk who is going to travel and not have easy access to
mm,
Paxlovid. So I think that's the bottom line. There should be that it's been deemed safe and longer term follow up, and there'll be a lot more flexibility for its use for individual situations and clinicians. And I really want to emphasize that Paxlovid is still a very underutilized medication and treatment for COVID. It's really the data on it are great as far as reducing severe disease and risk of death, even amongst vaccinated people.
mm,
So if you are 50 or over or at any higher risk, we really encourage you to make a plan. Think a little bit ahead of time, because you don't want to just think about it when you get sick. Think about how you would go about getting Paxlovid in a timely fashion, because the sooner the better for stopping that viral replication.
mhm,
Um, and so yes, and I don't, the rebound got a lot of news attention, but there's a lot of evidence that shows a lot of normal COVID disease kind of has two phases, where you might also have a return of symptoms in the second week. So some of that rebound was probably overestimated. But I think more importantly, even if you do get a little bit of rebound in the second week, it doesn't change the fact that it's really reduced your risk of being in the hospital. And so
mhm,
to me, that's, would be totally worth it. There's also some evidence that Paxlovid might reduce your chance of getting long COVID. So,
mm.
absolutely, let's use the tools that we have to fight this nasty virus, and Paxlovid is a really, really good one.
Thanks for the reminder to use the full toolkit. So that's all the time we have for today. Thank you for joining us. Lastly, I just want to mention that if you're not already subscribed to our newsletter, please do so on our website at thosenerdygirls.org. And yeah, you'll get, is it biweekly emails?
Yeah, we
Yeah.
get 2 times a week. I can never remember if bi-weekly is.
Two times a week, you'll get an email with our latest content. And if you have a question, please submit it to our question box also on the website. We can't respond directly to everyone, but it definitely does shape the direction of our questions, both our posts and the Q&A session. So thanks again for being here, and stay well, stay safe.
All right.
Take
Bye,
care.
guys.